So I'm going to present to you our study on predicting outcome of COVID-19. So also what we call the Danish intensive care unit risk study. So the whole idea is to look at what is the risk for subjects that get COVID of ending up in the intensive care unit, that since this has been one of the major steering parameters of the Danish government during the COVID pandemic in Denmark. So we are looking at the eastern part of Denmark, the capital region, Region Zealand, approximately 2.6 million citizens, and in the beginning of the pandemic, 80% of the Danish hospitalizations due to COVID. So we may normally think that the trajectory of patients are quite simple, but here you see just the first 1.5 months of the COVID pandemic in Denmark, the pattern of how patients move from being infected to going to hospital, maybe jumping over the intensive care unit and directly dying from there, or luckily the majority of the patients recovering in the end in this period. But it's a complex picture of how the patient move around in the system. In order to try to predict for the individual how they will move, here we are looking at their electronic health platform data, so that the electronic journal data, including drugs, delivery, administration, patient contacts, patient events, lab results, etc. And also in the common packs, we have access to their medical images there. So if we're just looking at the very beginning of the pandemic in Denmark, we could verify some of the international findings very early by looking at that it was the elderly people that would die due to COVID. It would be the people with relatively high BMI. So I have to move you around so I can handle the panel there. It would predominantly be males. Diabetes would be a risk factor, and also, for example, hypertension. A lot of all of these parameters come directly out of the electronic healthcare records when we look at it. Oops. So also when we look at the population going into hospital, we see it's mainly the elderly. If we look at those going into the intensive care unit, we have cut off the very elderly, and that's simply because there's no benefit of going to the intensive care unit for the very elderly, because they cannot, they don't have the physical condition to get into a ventilator. And you see the picture that we know so well, or all too well now, that the death is mainly in the elderly population. So when we look at the analysis of this, the data coming in the healthcare platform is a time train of different events happening for the patient. So we have one day they have a drug ordinated, another day we have a lab results, etc. And all these quite unstructured data coming in several channels that we have to analyze. So the way we are analyzing this in a machine learning setting is with a so-called autoencoder, where we get some variables out in the middle here, latent variables that have a simpler structure than the complex picture we had before. And if you look down to the right here, you see the overall picture in 2 dimensions of how the patients look in the electronic healthcare record, where we have to the left a huge variation in their patient conditions. And when we go more to the right, you see that patients get more and more similar. And those that are colored blue here are the patients that are in the intensive care unit. So it's like we start out very different, but then when we move closer towards serious illness, we all become more alike in this picture here. We can also see that if we look at this is a high dimensional point cloud, and we can also look at it from the tip here. So you can see, you can imagine you could turn it around and look at it from different angles, how the different patients in a one snapshot on one day, how they are distributed in this space of patient histories. We can look at two patients here. To the left, you see one that is starting out here to the left, then go into the intensive care unit, and then luckily later on get healthy and are back into the left part of the space. Whereas another patient also starting out here to the left goes into the intensive care unit, but unfortunately a couple of days later dies in the intensive care unit and leaving by the tip of the needle, so to speak, in this space. So when we look at how does that actually perform when we do predictions from these representations of patients, can we predict these various stages of the patients? We see that the accuracy measured as the area under the curve of the receiver operating characteristic curves, so I'll just call it accuracy now for simplicity, is 0.78 for going to the hospital, but we have a nearly perfect 0.9 prediction of predicting who will actually end up dead in the end. So this is when we look at at a random individual that get contaminated with COVID, we can with 90% accuracy say who will actually end up dead. This was before we got access to vaccines that we had this prediction, and it was the earlier variants of the COVID in Denmark. If we are looking at which parameters are actually the most important to predict whether patients end up in the intensive care unit, we can see here to the left that prior to patients coming to the hospital, where we have only have their comorbidity, their age and the BMI, you can see that BMI, age, hypertension, etc., are the important parameters to look at. You can also see quite high on the list, we have neurological manifestations here, and that actually led our findings here, the Danish government, to change the order in which people were offered vaccination. So people with neurological manifestations were given higher priority in the beginning of the vaccination coming to Denmark. When people had then entered the hospital, we see that all the lab tests and vital parameters totally dominate over their patient history as the most important parameter. So you can roughly say that it makes sense what they are measuring in the hospital, because that actually tells a lot about the patient status. Another part of it is that we can look at the lung x-rays. Here we are looking at thorax x-ray of the patients. We can do a scoring of how opaque are the lungs. And you can see a lot of opacity in this here, and we can score that automatically using deep neural networks. And we can see here that when the patients enter the hospital, those that will later on use a ventilator have a much higher opacity score in the lungs when they enter the hospital. So it's a predictor, fairly reasonable, that if the lungs have disease, you have a higher risk of going to the ventilator. So we can combine that into to our scores or our predictors, as we showed before. And here you can see that putting in the chest x-rays into the predictor of whether people will go to the intensive care unit or not gives a substantial evidence. So the chest x-rays are a very good predictor for whether the patients will need to go to the intensive care unit. So when we are looking at this, this was for the individual, everything I presented to you so far. Here you see we can use that to look at the whole population, because we have all the individuals in the capital region and the Zealand region in Denmark. We have all of them in the electronic healthcare record, because it's one system for the whole population in this part of Denmark. And we can actually predict here quite actually with only around 5 to 6% in accuracy how many people will be in hospital and how many people will be in the intensive care unit with 10 days in advance of that actually happening. The 10 days is also kind of the limit of how far we can predict, because much longer than 10 days, then we needed to predict who will actually be contaminated and not predict who that are contaminated will end up in the ICU, because that's approximately the time span it takes from contamination or a positive test until you would end up in the intensive care unit. So this can be used as an instrument for steering. And here you see the two first episodes of the COVID in Denmark, and then we stopped this prediction when we got the vaccines in place, because that ruined our capability of predicting. Thank you.
Thank you so much. Very, very exciting. Actually, I would say it goes back to my initial presentation, helping me prove that imaging does have a role in COVID. So my first question is if Denmark actually uses imaging in some population management.
So it is for every COVID patient entering the hospital due to COVID, they will have a chest X-ray taken. Not a CT, mainly due to that the wash time, downtime of the CT scanner is too long in between patients, but you can have dedicated X-ray machinery for the COVID patients.
Okay. Is it actually become, so it's a standard of care? Do you think they actually use this in the prediction, these kind of predictive models? Can they actually support hospital management?
So the predictive models have been used for doing it, but the major problem is also to do it clinic per clinic, and there we never managed to get it in place clinic per clinic, so we could use it for the whole population, but not for the individual clinics.
Okay. Also, quick question on the vaccines, and now that we have vaccines that are changing how we look, and the variants, how much effort to develop, to adapt the models, or do we need to redo?
So we actually, after the vaccines, we stopped using the model because we had a technical problem getting access to vaccine data, and they are so important for seeing how ill people get when they're contaminated. So the model wasn't useful any longer. However, the way we handle it then in the later part here was that when basically everybody in Denmark was vaccinated, we could retrain the model and then just assume that it was a vaccinated population we were looking at, and then the model became precise again. But in the meantime, where we had a partially vaccinated population, it was difficult.